Professor Magdi, please start the session. Dr. Ihab is online. Professor Hosam Agil.
Good evening. Okay, this is Novartis Symposium. It's my pleasure to co-chair this session with Professor Muhammad Qurayim, Professor Ayman Maher, and it's my pleasure to introduce my dear friend, one of the eminent speakers, my dear friend, Professor Abba. Dr. Ihab, do you hear us?
Yes, and I'd like to congratulate you for such a successful hybrid meeting. It's really excellent. If you'd like me to start, whenever you're ready.
Thank you very much for joining us, Professor Ihab. Professor Ihab is going to talk about heart failure with preserved ejection fraction. Professor Ihab.
Thank you very much for your introduction. Today I'm going to talk on the other side of the coin. The other side of the coin, which is the preserved ejection fraction and the progress that we are making all over the world to deal with such an entity, because it's really a tough entity to deal with, as we all know. It has been recognized since a long time. I mean, since 1984 and 1985, we all knew that there was a congestive heart failure with normal systolic function, as it was called during that time, and even they used to call it intact systolic left ventricular function in clinical congestive heart failure. So this entity existed from decades, but we did not actually give it enough attention during the time. Why is that? It's because at the time we were all interested in the reduced ejection fraction type rather than this. We didn't know what to do with it. That was the main reason. However, in the recent guidelines, the ESC guidelines 2012, again, they said that there is no treatment that has yet been shown convincingly to reduce morbidity and mortality in such patients with HFpEF. What about 2016, the ESC guidelines? It's the same statement. Still, there is nothing, no proven treatment yet. It's a difficult entity to treat. This is what we have to recognize. So, it is actually one of the greatest unmet needs in cardiology up to date so far. So today I will discuss with you why is HFpEF important and how can we diagnose it, as well as importantly, what progress are we making currently. So why is it important? Because it's been recognized that it's increasing in prevalence, and the prevalence is increasing year after year, 1% relative to reduced ejection fraction. So we can see from 2005 to 2020, when we look at 2020, we find that almost 65% of hospitalized heart failure patients have an ejection fraction of 40%. 50% with an ejection fraction above 50, which is true preserved ejection fraction, and maybe around 15% with an ejection fraction between 40 to 50, which is the so-called mid-range ejection fraction. Also, when you look at the trends in incident heart failure as studied in Olmsted County, and why Olmsted County? Because you all know that Olmsted County is in the state of Minnesota, and you all know that the largest largest city there is Rochester, with the famous Mayo Clinic. So this is a Mayo Clinic study, and Yarof Gerber, he found that the incidence of HFpEF is increasing, and when he compared from 2005 to 2010, and you look at the right side of the table, the right side of the table shows the HFpEF, we find that it increased from 47.8% to 52.3%. And more interesting, when we look at the characteristics that are associated with HFpEF, we find that there is more prevalence of hypertension, diabetes, dyslipidemia, as well as, very important, a lot of comorbidities which increase over time. Such that at one point they decided that HFpEF may be just a mix of comorbidities. And this is partly true because comorbidities and non-cardiovascular risk are relatively more important in this entity, HFpEF, and the key word is that they are variable among different patients. There is inter-individual variability. And when we look at the studies that studied the HFpEF, like TopCat, CHARM, PRESERVE, iPreserve, is it only related to age with comorbidities? I mean, is it because there are young individuals with HFpEF that differ from elderly individuals? For example, when you look at the clinical characteristics in young hearts with preserved ejection fraction, mainly males, these, even the cardiac structure and function is different. Concentric hypertrophy, more rise in filling pressures and increase in left ventricular volume. We look at the elderly. Heart failure with preserved ejection fraction is more common in women. There is more atrial fibrillation, more hypertension and renal disease, and the structure mainly increase in left atrial size. And the clinical outcomes are also different. In the younger age, there is increased cardiovascular cause of death and increased sudden cardiac death, while in the elderly, it's more increased in non-cardiovascular causes of death. So as you see, it is not one entity, it's different entities. This is what makes it hard. And the importance of diagnosing HFpEF is because mortality is higher than that observed in other cardiovascular trials. Any other cardiovascular trial, when you look at them, whether the hypertension trial, or you find that the HFpEF trials like iPreserve, CHARM, PRESERVE, ejection fraction, find the mortality is much higher. Not only the mortality, but also the increased heart failure hospitalization compared to the other trials. It's still much more common in these individuals with heart failure with preserved ejection fraction. So, how to diagnose this is really an important matter because it's not that easy. When we look at the clinical characteristics of HFpEF, I look at all these studies, and you see the difference in characteristics. I'm going to try to summarize it, so you don't need to read all this complicated table. We will find that in HFpEF there is more elderly individuals aging from 74 to 78 compared to reduced ejection fraction. Majority is women, like has been shown. Hypertension is more prevalent, 55 to 84%. More coronary artery disease, 34 to 53%. Atrial fibrillation is more common. Diabetes, as well as obesity, they are all more common compared to heart failure with reduced ejection fraction. So these are characteristics we should be looking for when we're trying to diagnose HFpEF. Also, when we look at the international guidelines, they recognize that there is complexity in diagnosing HFpEF. This is because there are non-specific symptoms and there is need for more objective diagnosis. So both European and American guidelines, they recognize this complexity and they recommend that the diagnosis should be based on finding symptoms typical of heart failure, signs typical of heart failure, although they acknowledge that signs may not be present in the early stages, especially at HFpEF, early stages, and particularly in patients treated with diuretics, you may find no signs. And these people will have normal or only mildly reduced left ventricular ejection fraction. However, the European guidelines also specify, in order to help in the diagnosis, to get objective evidence of other cardiac functional and structural alterations, to look, which is very important at the elevated levels of natriuretic peptides to carry out a stress test or maybe invasively measure the elevated left ventricular pressures. The American guidelines also said that it's important to get the left ventricular diastolic function as determined by Doppler echocardiography or even cardiac catheterization. And they recognize that after all this, diagnosing FF is very challenging, and mainly because we need to exclude all other potential non-cardiac causes of symptoms that are similar to heart failure before we reach a final diagnosis. So for example, if you look at the symptoms and signs, if you compare HFrEF and HFrEF, it's similar. I mean, there is a third or fourth heart sound, pulmonary congestion, edema, hepatomegaly, so not much difference there. And this may be a cause from the Mayo Clinic, Reddy and his colleagues, to try to devise a simple evidence-based approach to helping diagnosis heart failure with preserved ejection fraction, and they tried to look at the parameters and they developed the HFpEF score. The HFpEF score, the H has 2 points because it looks at obesity, heavy, and hypertensive, and it gives them points. You can see at the very right column, there is the points given according to the body mass. It's about 30 kilograms per meter of hypertensive, 52 or more drugs. Atrial fibrillation doesn't matter if it's paroxysmal or persistent, it gains 3 points. Pulmonary hypertension as measured by Doppler echocardiography to measure the systolic pulmonary artery pressure above 35, age above 60, and again the Doppler echocardiography E over E prime ratio is above 9. Finally, you calculate and add all these points and you get a maximum of 9, and you look and see the probability of HFpEF according to the points you get. So for example, if you have 5 points, you have a probability of about 85% that that individual has HFpEF. So it's, I mean, it's some score that may be helpful, although it's not the whole idea. We have to look again to the trials that gave us important messages. And the top cat highlighted the importance of natriuretic peptides in diagnosing HFpEF. And in that trial, when they enrolled patients on the basis of natriuretic peptide entry criteria, we find, when you look at the placebo arm, we find there was a higher prevalence there, just based on the natriuretic peptide, much more than even if that patient had hospitalization in the year before because he was managed for heart failure. The natriuretic peptide was much more important. So this is another thing to keep in mind. Also, to help us in the diagnosis of HFpEF, we know that transthoracic echo is the method of choice, easy for us to do to evaluate the diastolic function of the ventricles. You can do a stress Doppler echo again to detect diastolic dysfunction that is only apparent after exercise. The cardiac MRI is the gold standard. You want to measure the mass of the ventricle, to get the volume, the ejection fraction, to look particularly at the myocardial fibrosis, which is very important. And sometimes you need invasive hemodynamic assessment to help us reach the diagnosis and prove it's a definite heart failure with preserved ejection fraction. So, coming to my last point in my talk, it's what is the progress we did to treat and manage HFpEF so far? Well, when we look at all these trials, I don't want you to read all these trials, but they include the ACE inhibitors, ARBs, beta blockers, digoxin, spironolactone, even things like riosigua that worked in the Victoria trial, but did not work in the capacity trial again. And you find that even such agents like nitrates or inorganic nitrates, they were all neutral. There was no benefit there. So the guidelines tell us that we can use diuretics in congested patients with HFpEF or have mid-range ejection fraction in order to improve symptoms and signs, but not to improve mortality. And it has a class of recommendation 1, level of evidence B. Why is that? Why do these current therapies all fail? Because we are trying to use the same treatment for 2 different entities, the reduced ejection fraction preserved ejection fraction. We are trying to use one size fits all approach, which will not work, because we all know that HFpEF is a heterogeneous syndrome from different phenotypes. And if you use the same treatment, some will improve, some will derive more benefit, and others will worsen. So we cannot use one size fits all. That's why a lot of researchers have looked at new molecules to see if they may help. And one of these molecules is armin, cyclobutyryl valsartan. And as early as 2012, when it was published in The Lancet, you are all aware of Paramount, which was a phase 2 double-blind randomized controlled trial, and they looked at the surrogate endpoints of improvement in natriuretic peptides, NT-proBNP, which showed quite significant improvement, but it was really a short duration, but it showed an improvement. It showed an improvement in left atrial size, as well as improvement in New York Heart Association when it was compared to valsartan. So this encouraged the researchers to study the HFpEF with the army again until we all got the study of Harvard published again in 2019. And Scott Solomon reported the trial. It was the first randomized trial for HFpEF designed versus an active comparator. And here I would like to stress that it was not versus placebo. It was versus an active comparator, which was valsartan at 160 milligrams twice daily. If you look at all the other trials, looking at HFpEF, whether it was ACE inhibitors, ARBs, MRAs, they all were at the top of current standard of care therapy versus placebo. So this is a different issue. These looked at versus valsartan, and when you look at the primary endpoint, looking at the total heart failure hospitalization and cardiovascular death, you will find that the relative risk reduction was 13%. However, it just missed the statistical significance. The p-value was 0.059. So it missed statistical significance slightly. So we cannot say that it showed a significant value, but we have to look further and look at secondary endpoints. And when we look at secondary endpoints, which is very important, we look at the New York Heart Association functional classification at 8 months, and we look at the change from baseline. And we find that there was an improvement which was statistically significant between both arms. When we look at the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, again at 8 months, it just missed statistical significance. And when we look at the responders, it was significant. And more importantly, the renal protection, it was quite significant. There was more renal protection with the army compared to valsartan alone. So look, there was much less worsening of renal function. However, we have to acknowledge that there was no change in all-cause mortality. Again, when you look at the multivariate analysis, there was significant heterogeneity. And it was found when we looked at sex and ejection fraction. And these were the only interactions that remained nominally significant in this study. When you look at the female sex, it showed value, they showed benefit compared to males, with a p-value less than 0.006. When you look at the ejection fraction, and you look at those that had below a median of 57%, there was much more significant benefit than those who had an ejection fraction 57% or more. And this tells us that there is a subgroup that may benefit. The women and those with an ejection fraction that fits the diagnosis of HFpEF or even HF with mid-range ejection fraction. But the true, the mid-range ejection fraction, but the ones with the true preserved ejection fraction maybe will not fit that. But we should look at females and maybe look at those with mid-range ejection fraction. These may benefit. Another study came out recently at the ESC last August, which was the parallax study, looking again at RP, this time comparing it with individualized medical therapy for comorbidities, which are very common, like I said, in HFpEF. And when we look at this study, we find that this study occurred in 32 countries. It was a 24, it's a short study, 24-week randomized active controlled parallel group trial. And the primary endpoints were looking at the change in NT-proBNP at the 12th week and looking at the change in the 6-minute walk distance at the 24th week. There were other secondary endpoints, namely quality of life and change in neural heart association functional class, all of them at week 24. I want you to look at the right side of the slide. The patients after being screened were randomized to 3 categories. Category that was tested with ARMI versus an ACE inhibitor, which was enalapril, 10 mg BID, and another category with ARMI versus ARB, which was valsartan, 160 mg twice daily, and the third category, which was ARMI versus placebo, no RAS inhibition. Why did these patients take an ACE inhibitor or ARB? Because they had to have a history of hypertension that required treatment by these agents. But if they did not have hypertension, they did not receive any RAS blocker. The key inclusion criteria, as you can read for yourselves, age more than 45. Importantly, the left ventricular ejection fraction was more than 40%. So it included those with mid-range ejection fraction as well as preserved ejection fraction. Comparison to Paragon, symptoms of heart failure, the New York Heart classification from class 2 to 3, required diabetics, structural heart disease. I mean, you can read all the slide. I don't need to read the slide for you. Importantly, is that the Kansas City cardiomyopathy questionnaire clinical summary score had to be less than 75, meaning that these patients have to have a poorer quality of life than seen in the trial like Paragon, because you know that the score, the higher the score, the better the quality of life, the lower the score, the worse the quality of life. So in this trial, they insisted that the score should be below 75, because if you're above 85, you are class 1. So less than 75, you fit the description of class 2 to 4. Look at the primary outcome, and we look at the NT-proBNP. And remember that the primary outcome was looking at week 12. And when you look at week 12, there was a significant value for using ARMI compared to individualized medical therapy, and the p-value was very significant. And you also look at the 6-minute walk distance, there was no difference, no benefit. And the p-value was not significant in this group. Also, when you look at the secondary outcomes, looking at the different Kansas City cardiomyopathy questionnaires at the week 24, even the New York Heart Association class, we will all acknowledge there was no significant difference. But more importantly, we as clinicians would like to look at exploratory endpoints. These are clinical exploratory endpoints that matter to us in our clinical practice. And when we look at the renal protection and the change in EGYHF, it was much better with sacubitril valsartan compared to individualized medical therapy. It was quite clinically significant, and this was a pre-specified exploratory endpoint. So this was pre-specified in the trial to look at. Another point was cardiac failure events leading to death or hospitalization. This was a post-hoc analysis, and again it showed the clinical statistically significant value of sacubitril valsartan compared to individualized medical therapy, whether it was the first hospitalization due to heart failure, or was it composite of time to death due to cardiac failure or heart failure hospitalization. So the conclusions was that there is no current established treatments for HFpEF, and RAS inhibitors are often used because we use them to treat comorbidities of these patients. So this is why the Parallax studied the benefits of sacubitril valsartan compared to background therapy in such patients that included mid-range ejection fraction as well as preserved ejection fraction with a high prevalence of comorbidities, and more importantly, these were patients with a poor quality of life. It showed that there was significant reduction, like I showed in the NT-proBNP at the 12th week. However, there was no additional benefit in 6-minute walk distance, and the other parameters of quality of life did not show any benefit at this short duration. And the benefit that we saw was in renal protection, like I showed, and reduction in cardiac failure, serious adverse events leading to heart failure, hospitalization. So these results are consistent with the findings of the Paragon that had patients with an ejection fraction above 45, and they give further evidence to a potential benefit that we could be using. Why I'm saying potential benefit? Because if you intend to use a RAS blocker to treat a patient with HFF who has hypertension or other comorbidities, that you are going to use a RAS blocker, so in such a patient, maybe the use of cyclopentone will be more likely to be used, since we have some data saying that it has a potential benefit there. Anyway, the message from these trials is that we know that more than half the patients that have heart failure have FF. The prevalence is going to continue to increase. It is difficult to diagnose, like I showed you, and I'm not going to repeat, but the Paragon has shown that there is a potential benefit of ARNI compared to consultant in reducing heart failure hospitalization in these patients. And like I said, the Parallax showed significant clinical and renal signals in the exploratory post-hoc analysis, showing that there are some benefits that you can get, and these are consistent with findings of Parallax. So again, like I said, there is potential benefits of using that. Are going to use an acid blocker. That HFF is a comorbidity with liver inflammation hypothesis. It is a distinct syndrome. It's different from the reduced ejection fraction. And you can see we have on the left side, comorbidities is more important, microvascular inflammation, hemophilia, activation. You have the tightened phosphorylation. You have to look importantly, tightened phosphorylation is important for the passive strength of the myocardium. It's important for the stiffness of the ventricle. And we need agents to act on this phosphorylation. We have to find agents to act on the microvascular ischemia for concentric hemopathy. On the other side, there is reduced ejection fraction. We all know about it, and we all know how successful agents. But we have to know that the FF is a distinct syndrome. It's a completely different category than HFF, and we have to look for completely novel treatment strategies. And this is why all the pharmacological treatment targets that currently are under investigation, they are looking at a lot of drugs to work on the immune system, the GI tract, the hemophilia, the kidneys, the skeletal muscles, the lungs, and then the heart. All these are being looked at. And why is that? Because we need personalized precision medicine. If we are going to be successful in treating heterogeneous syndrome like HFF, we have to look at personalized precision medicine. We have to look at advanced image analysis, tissue analysis, in order to diagnose exactly what this particular patient has as a problem. And so we target the treatment according to this problem. In this case, we will expect that most of the patients will improve if they get personalized treatment. And when I say personalized treatment, we have to look at what is currently being studied. These are the current pharmacotherapeutic clinical trials heart failure that are going on with HFF, and they are looking at a lot of different agents, oral nitrites, potassium nitrates. You can look at even, like I said, soluble release cyclase pathway, the capacity, which unfortunately failed a few months ago. You can look at spironolactone and spirit, which is going to be published in the coming 2 months. But when you look at the very right side, the right column, and the primary outcome, they are all surrogate endpoints. There is no really hard endpoint except for the spirit trial, where is the time to death from any cause. And when we look at the other trials, these are the other trials that we are waiting for. We are looking at preserved heart failure, emperor preserved, and looking at, importantly, the treatment of the special phenotype of pulmonary hypertension, because this is a unique phenotype of HFF, and we have to treat it with, like we always with the antagonists, and we have to use the other agents that we treat pulmonary hypertension with, newer drugs that deal with calcium handling and interleukin-1 interference, mitochondrial dysfunction. But sorry, again, all of these are looking at surrogate endpoints. The only one that's looking at a hard endpoint is emperor preserved. It's looking at time to cardiovascular death or heart failure hospitalization, and we still have to wait for this study to be finalized and published. But at the end of my talk, I want to say that HFpEF is a heterogeneous, multi-systemic, multi-organ syndrome. And phenotyping that type of HFpEF is very important for proper diagnosis and treatment. And the exact phenotype should be matched to the precise treatment. And no more should we do like this man is doing, and just choose any treatment from the HFrEF and just throw it like we're throwing a dart blindly and expect it to work. It will not work. Thank you very much for your attention.
Thank you, Professor Ehab, for this comprehensive talk. I want to ask you about the scopotriol therapy. You said it improves the quality of life in some patients. You recommend to whom for patients with which patient will get benefit from using scopotriol therapy from all these levels?
The audio wasn't working. Can you please repeat the question?
For scopotriol therapy, it improves the quality of life in some patients. You prescribe to whom?
Well, currently there are no strong guideline recommendations, but we are trying to extrapolate. Like I said, if I get a patient that I'm going to give an ACE inhibitor or an angiotensin receptor blocker, because this patient is hypertensive or has other comorbidities, diabetes, chronic artery, whatever, I'm going to use it. Maybe if I use the army, I can get some benefit. But however, we still have, honestly, we have to wait for more solid evidence. But if I'm going to use such a RAS blocker, I might use an army because there is some evidence that the quality of life may benefit there. And like I said, if I look like a subgroup of a woman that comes with an ejection fraction that is 55, 54, somewhere in the mid-range, maybe she will benefit from such a molecule as has been shown in the subgroup analysis. I hope this answers your question.
Thank you.
Professor, you have excellent presentation as usual, and as you mentioned, it is a heterogeneous disease, a lot of phenotypes, a different response to treatment, a lot of comorbidities. So, parallel trial was associated with reduction in NT-proBNP level. However, there was no clinical benefit, and this is compared with paradigm. The reduction in NT-proBNP level was associated with clinical benefit and remodeling benefit in terms of reversing the remodeling. So, what is the difference between reduction in NT-proBNP level in both trials, Paragon and Paradigm heart failure trial?
Well, when we look honestly at the reduction in NT-proBNP, you also have to look not only on parallel, but when you look even on parallels. It went down at the 12th week, but again, the difference was reduced when you continue looking at the 24 week. You even lost this reduction NT-proBNP with time. So apparently, like I said, the HFpEF is a different animal. It's not like the HFrEF. This is why we did not find any translation into hard endpoint clinical improvement. So it's all just surrogate endpoints. We are trying to make something what data, little data we have, because we are desperate as physicians. We have nothing to offer our patients. We have diuretics to offer them, and other than this, we have nothing. So we are trying to use these agents. But you are absolutely right. There is no comparison to the benefit achieved with the FF. And the reason is we have two different animals. Like I said, the pathophysiology is completely different.
So for the sake of time, thank you very much, Professor Ehab, for the highly informative presentation. Thank you for joining us today.
My pleasure.
now we'll close this session.